Hi everyone, welcome to Justice in Motion, and thank you so much for being here with us today. My name is Lainey Johnston, and I'm the Senior Program Manager for Diversion Initiatives at the Mayor's Office of Criminal Justice. And today I have the pleasure of introducing our first panel, One Team, One Dream, which will focus on what it takes to support individuals dealing with complex behavioral health needs at the intersection of healthcare, community services, and the justice system. As we'll hear throughout our panel, effective responses to individuals with behavioral health needs requires more than any one system can provide. It requires collaboration, compassion, and a commitment to seeing the whole person. We have an incredible group of panelists for you today, and I'm looking forward to hearing each one of them share their experiences, challenges, and insights on what it takes to create meaningful pathways to care and stability. So please join me in welcoming our moderator, Esmeralda Herrera, Director of Capacity at Echoing Green. Alex Presepe, Senior Director of Justice Initiatives at the Community Health Action of Staten Island. Monica Moya, Director of Practice for the Supervised Release Program at the Staten Island Justice Center. Justina Ruinski, Clinical Director for the Supervised Release Program at the Staten Island Justice Center. Assistant District Attorney Jason Cohen, Chief of the Alternatives to Incarceration Bureau at the Richmond County District Attorney's Office. Lamarr Hazel, Peer Specialist with Bronx Community Solutions, Bronx Hope Program. And Sasha Gaye-Bailey, Director of Crisis Services at Services for the Underserved.
All right, what's up, everybody? Something to know is that I'm from the Bronx, and this is my second time in Staten Island, and I have to say, it's a really, really nice, beautiful day for something like this. So you can see we have some pretty extraordinary folks up here with lots of expertise, lots of knowledge, and I can't wait to learn from them. So we're gonna get started. You already know who they are, and so I think we're just gonna jump in and get to know a little bit about their expertise. So we got a good first question here, y'all. And that question is, what misconceptions do people often have about working with individuals who are experiencing behavioral health challenges? And you know, we're just gonna do a whole roundabout here, and we're gonna get started.
So something that I've heard, I've been doing this work for 8 years, and from friends and family, you always get questions about, you know, are you safe? Am I safe at work? And I've never felt in danger in my entire time of doing this work. Thank you. Okay. So sorry, I'll repeat myself. I think the mic was off. So I've been doing this work for 8 years, and something that I've always heard from friends and family is, am I safe? Am I safe going to work? Am I at risk? And I've never felt at risk or in danger in my entire time of doing this work. I've worked with people with mental illness for 8 years, and out of that 8, 4 of those are people with substance use diagnoses. And you know, the reality is that the data shows that people with those diagnoses are more likely to be recipients of violence. So the facts are on that side where we're not at risk doing this work. The people are not posing a danger to us. They need help and they need support.
Can you guys hear me? Yes, okay, great. I would say I think a misconception working with our participants is that they come in and they're unmotivated or they're unwilling to receive services. Sometimes they're even unwilling to talk to us. And I think what it comes down to is prioritizing getting to know our participants, learning.
If not, just use that one.
I think maybe just pass Alex's around.
Okay. Prioritizing getting to know them, their history, and then kind of working based on that. Prioritizing also meeting them with respect, meeting our participants with respect. It's definitely a two-way street with openness, with transparency, and then most importantly, consistency, because I think that is what people are lacking sometimes in the community. Consistency and just the respect of being transparent and treating them like humans, you know?
Yes, I agree with Alex and Monica. I think the biggest misconception is that people with a serious mental illness are violent, unmotivated to treatment. But working in this field for so long, that is the opposite, and it is not what we see like on TV and what the media portrays. These individuals, we do feel safe around them, and they are motivated to do treatment and get resources.
I think coming from the law enforcement perspective, one of the things that I hear often from my colleagues and other people in law enforcement is this idea, I think that a lot of people have, that individuals who are using substance, they do it because they want to, they do it because it's fun. And in reality, in working in this field, you learn that a lot of people are either self-medicating for mental health issues that they're dealing with, or they're dealing with very serious and complex trauma and using substances to deal with that, to mask that. And you know, one of the things that I stress, especially to the younger ADAs, I do a training when they come in the office, is that individuals who are committing these petty crimes, who are in and out of the criminal justice system, especially because of substance abuse and mental health, they're not doing this because they want to. They're not doing 20 bags of heroin a day because they think it's fun or they think it's cool. They're doing it because they have to, because if they don't, they're either going to die or they're going to feel like they're going to die. And that's something that I really stress to people. And then the other thing I think that's a misconception is that, you know, we have these individuals who've been arrested a number of times and we've offered them some sort of treatment. And maybe they've done a program, maybe they've done Alex's program, maybe they've done it twice, that, you know, well, he did a program already and he's still using drugs, so he needs to just go to jail at this point because he's gotten an opportunity, when in reality, we need to keep trying until it clicks, because you never know when it's actually going to sink in and this person is going to, you know, realize and move forward with changing their life. And there are a lot of different things, whether it's housing, whether it's resources, that make that thing click. But I think that's another big misconception from the law enforcement end of things.
Thank you. My name is Lamarr, paraspecialist, Bronx Hope, Heroin Overdose Prevention and Education Program. One of the biggest misconceptions is that they'll never change. They'll always be the same. It don't make sense to try to help them. Do not help them. They'll do the same. They'll end up back in jail again. That is a misconception. People can and will change. We have to be there for them. We have to be there for them. And the warm handoff, the follow-up through the whole recovery process and whatever resources we can provide to them, I believe they can change. Thank you.
Thank you, Lamarr. Hello, everyone. My name is Sasha Gaye-Bailey. I'm the Director of Crisis Services for SUS. And I believe that one of the misconceptions about mental health and substance use is that, you know, people are treated the same, right? And we're going off of a textbook definition of what mental illness looks like and what substance use looks like. But I think we need to kind of steer away from that, because each individual is unique with their own personalities, you know, background, all of those things. So I feel like going based off of the textbook definition is not really helpful, because we're helping to stigmatize people in a negative way instead of meeting individuals where they are and understanding what their needs are and how we can support them. So I do believe that that's one of the misconceptions.
Thank you so much to all our panelists up here to get us started, to talk about their experience and what it looks like to have these misconceptions. What are these misconceptions? So we have a few more questions here, and Jason, I want to go back to you, because you talked about, you know, from this law enforcement perspective. Tell me a little bit more, like, what trends are currently developing at the intersection of behavioral health and the justice system?
Well, so I think I've been a prosecutor for a little over 10 years now. And before that, I worked as assigned counsel for individuals with mental health issues and developmental disabilities. When I first started as a prosecutor, I say all the time that treatment was something you did with a bad case, because the first priority was always jail. And on the cases where you're like, this case, it's not the best, like, I guess I'll give him treatment just to make it go away. But the focus was not treatment. And I think over the last 10 years, there's really been a sea change, both from the district attorney's office perspective and also in the courts, in treatment really being the first priority. Our DA McMahon, as soon as he took office, he created the HOPE program, which is a pre-arraignment diversion program. He also created the overdose response initiative, where every time someone overdoses on Staten Island, we look into that as though it was a crime. And I have a team of peers in my office. We reach out and we give services to those individuals. That was something that was unheard of 10 years ago, because the focus was really jail. And now we divert 40% of the cases in our office. I have a fantastic team that I work with every day, where our peers, David and Austin, they're down in the court part. They're Narcan training people. They're trying to get them connected with services. Chassie's a huge partner in that. Alex and her team have been great. And so, I think that's really been the trend, to where now, we're expanding. The judge just reached out. He wants to add another day to our treatment court calendar. It started as one afternoon a week. We're now up to 3. We're about to add a 4th. So I think the fact that understanding we're not going to jail our way out of this problem. If you have an individual who is a heroin addict and you send them off to Rikers Island for 5 days, when they come out, they're still a heroin addict. They're still going to keep committing those same things. And in fact, all you've done is really stigmatize them and add to the trauma that's causing them to use. If someone's schizophrenic and they're committing crimes because they're unmedicated, sticking them in Rikers Island for 10 days, a month, when they get out, they're not getting any services. They're still unmedicated. They're going to keep committing these same types of crimes. So I think that criminal justice has really realized that the way to stop recidivism isn't to jail your way out of the problem. It's to help these people, get them the treatment that they need, get them the reentry services that they need when they're getting out, and break that cycle.
Yeah, thank you so much for sharing that, Jason, because we can't jail them out of the problem, right? You talked about 40% of cases are now, the first step is treatment being the priority. And Lamarr and Sasha, I want to go back to you guys, because you talked about, everyone's unique. You talked about this misconception that people don't change, but we have to be there. We have to meet them where they're at. And so can you tell me a little bit more of how do you build trust and engage with participants who have behavioral health concerns or repeated system involvement?
Thank you. Good question. One of the ways I do that is I respect, I look them in the eye, and when possible, when necessary, I share my own experience with the topic at hand, just to build up the trust. We have to build up trust. So I'll share my experience with them to let them know that they're not alone. People don't want to feel alone. They don't want to feel the stigma. So I will share some of my experience, if necessary, and just let them know I've been there where you were at. I understand where you're coming from. It's not like the textbook. No, I'm not coming from the textbook. I'm coming from lived experience. I am a peer. District Attorney just talked about that. I am a peer. And the diversion program, it does work. We have one in the Bronx. We work with all 12 precincts in the Bronx. 24 hours, 7 days a week, we're on call. Give us a call, and we will meet them and engage them. Not only that, we'll give them a crisis bag. We'll give them toiletries. We'll give them a Metro card, something to eat, and some information, and follow up with the information that we give them.
Thank you, Lamarr. I think that's beautiful work that the peer specialists do every day, working alongside the clinicians. I believe that the peer specialists, play a decent role in the support that we provide to these individuals. And one of the things that I want to talk about is treating people as human beings, right? And I know many of us have been in this field for a very long time. And so we become, kind of numb to the work. It becomes repetitive. And, we see clients every day and we kind of get lost in the sauce a little bit, right? And I think when we treat people as human beings, we give them a sense of dignity despite the challenges that they're going through, and we meet them where they are. And I've heard a lot of people on the panelists today mention that. It's about understanding who's sitting in front of you, what are the needs that they have, and how can we support them, right? And assessing from a holistic point of view is also very important, because even though we're supporting people with mental illness and substance use, they may need medical attention, they may have food insecurities, they may have housing insecurities. So we can't bypass a lot of those needs that individuals have. And one of the things that I like to work from is the Maslow's hierarchy of needs, which is working on the basic things first, right? Do people have food? Do they have shelter, right? Do they have a sense of stability in their life before we can tackle the larger crises that they're facing, right? Because everything is integrated. And so we utilize the integrated model, the integrated approach, meaning mental health, substance use, medical, housing, all of the necessary needs that people face each and every day.
Thank you so much, Lamarr and Sasha, for providing more perspective of you have to treat folks like they're human beings, right? And providing these first resources. Monica and Alex, I'd love for you guys to add a little bit more to this question of how do you build trust and engage with participants who have behavioral health concerns or repeated system involvement? Monica, why don't we start with you?
Sure, thank you. I think one of the areas that we have to keep in mind is that when participants come in, it's important for us to be aware and to kind of inform our practice in our sessions on the fact that they come in with feeling a loss of control, a loss of choice, a loss of freedom. And I think that does also inform what types of resources we're providing for them, what are the immediate needs that we're addressing in that moment, and giving them the opportunity to kind of call the shots in that regard and letting us know what they need rather than us deciding for them what we think they need.
Yeah, and to add, to all that great input from everyone else on the panel, seeing them as a whole human being from a person-centered approach is really important. They're not just coming in as someone in the justice system or someone with a mental health diagnosis or substance use need. They're a human being, they're a whole person. And talking to them like they're a person, viewing them as a person is incredibly important with building trust. And the language that we use is incredibly important. Like, we don't view our clients as criminals. Yes, they've been arrested. Yes, they're involved in the system. But the driving factor behind the arrest, as Jay talked about earlier, is mental health concerns, substance use concerns, lack of housing. They need these supports. And if these things were addressed, it's very likely that a lot of these people would not have been arrested in the first place. So not viewing them as a criminal. They're a human being who's been arrested, who's been involved in the system. And when we talk to them about these things, when we do intakes, we have those conversations. We see you, we hear you.
Thank you. I really love that perspective of folks are calling the shots, and all the programming that you all do. And so Justina, coming to you, as we think about participants calling the shots, tell me a little bit more some of the components of your program that you're most proud of, that folks are maybe calling the shots on or otherwise.
Thank you so much. Yeah, so the components that I'm the most proud of in our program is that we provide so many services to our clients and really assess for their needs. So it is a supervised release program where they do have to do their check-ins, but that's not just what we focus on. We focus on looking at the person as a whole and really seeing what is happening in their life and how can we assist. So we do offer housing resources, employment, education, information to food pantries. We also bring a lot of community partners on site so that our clients can be easily connected to them. And I think that is so important because it is not just about them going to court and making their check-ins, but also for them to live a healthy life so that they do not get in trouble again with the law. So I think that is an amazing work that we're doing at the center.
Great. And Jason and Lamarr, I'd love to hear you guys. Are there any gaps or barriers that exist in programs that support those living with these co-occurring needs?
Sure. Before I get started on that, I just want to chime in on something that Lamarr said, which is that lived experience and how important that is. Because I can go to court and I can say to somebody as the DA in the suit, hey, this is what's best for you. You can go to this program. You should do this instead of taking your 5 days in Rikers. But to have someone like you or like David Claros, who's on my team, Austin Johnson, who's over in court right now, saying, hey, I've been there. It gets better. I have that same experience that you do, and look at where I'm at, is such an important piece. So thank you for the work that you do. As far as gaps, I mean, I say that the biggest gap that I see is housing. The amount of people who get out of Rikers Island and we expect them to do a one-year program, and we say, okay, you have mental health issues, you have substance abuse issues, you're going to do a 28-day, and then go to a shelter. Because there's nowhere to place you. There's no supportive housing. There's no places for these individuals to get the services they need and have stable housing. And then we're surprised when they relapse. Right? So you have this person, they either just got out of jail or they just got out of a 28-day or even maybe sometimes a 9-month to a year-long program, and there's no stable housing, there's no supportive housing, there's no sober housing. Right? We make it so difficult for people to get housing from the city and from the state. And we go, oh, well, you know, technically you have an address because, you know, the home that you can't go back to because there's an order of protection because you stole from your mother, that's on file. So go live in a shelter where everyone is actively using and where there's no one there to help you with your medication management. But if you mess up, you're going to upstate for 5 years. So we're setting people up to fail time and time again. And then when they do relapse in the shelter, we're shocked. You did a 28-day rehab. You should know better than this. You're going back to jail and we're going to start the whole process over again. And then what's supposed to be a year-long mandate takes 5 years. So I think that is the biggest gap. I will also say that I'm a believer in I think that assisted outpatient treatment is a good thing. I think that ACT teams work. I think that it is way too difficult for people to get services from ACT teams. And I think that ACT teams are not funded in New York, and especially on Staten Island, enough. So instead of getting the constant services these people need, it's like dealing with the cable guy, right? They give you this large window. Be in your apartment between 12 and 7 p.m. and someone will come and give you your medication. But if you're not there and we knock on the door, we're just going to leave. And then you don't get your medication, and when you decompensate, well, now you're going to go back to jail. So, you know, it's without these services there, I think we're just setting people up to fail. And then when they do fail, we act like we're surprised, and we act like it's not the system's fault.
Thank you. Thank you. Thank you. Some of the gaps and barriers that is confronted are a lot of times the training, knowing how to live by themselves all over again. They have to be. There have to be something there for them to learn how to live on their own again. A lot of the clients don't know how to live on their own. They don't know how to take care of that place. It will be destroyed. I've seen it, right? So Bronx Hope, what we do is follow up. We follow up. Bronx Hope follow up with peers. After the handoff, not just say, here's a Metro card, just go there. No. How about Bronx Hope escorts them to the place, right? And the gap The gaps are far and many because there's very few resources, educational, money-wise, the housing thing, the vouchers, and they give them out and say, here, go. So that's a gap because people don't know what to do. So we need to hold these trainings, train them. Listen, here's how it's gonna go. We're not gonna abandon you through your whole recovery process. Once you get out of the 28-day, right? I'm in recovery. Yes, I am. 34 years clean, I'm in recovery. And it does work. There's some follow-up. There wasn't none of this help for me when I was there. But now the help is here, so let's do something about it. The barriers and the gaps, we're closing them. We're closing them big time. Thank you so much, Jason.
Lamarr, Alex, I would love for you to come in and chime. So like Lamarr and Jason, they talked about that the gaps are far and many. And the system, as much as we are supporting, we're still setting up folks to fail a little bit. Is there something that you want to add in terms of the gaps and the barriers that you've seen?
Yes, so as far as treatment goes, a lot of individuals really would benefit from inpatient, long-term care and support. And a barrier is that if somebody is living with a serious mental illness and also a substance use diagnosis, it can be quite difficult to get them admitted into an inpatient program. A lot of the time, depending on what the diagnosis is, if they're medicated, if they're not, if they have any history of suicidal ideations or attempts, they end up getting denied from the inpatient programs because they don't have the staffing support. So it's really important to invest in the workforce and make sure that these programs have, people who are clinically trained to be able to assess for mental health issues, people who are clinicians in these programs, and a lot of the time it doesn't exist in these programs. I've had experiences where, we've had individuals where I've called inpatients upstate in Pennsylvania, New Jersey, and there are some people that there's nowhere for them to go. There's nowhere for them to get these resources. And then the cycle continues and perpetuates because that long-term care, the long-term support for people with mental illness and substance use, it's unfortunately, non-existent sometimes.
Thank you. And Sasha, I know you know a little bit about these insurance limitations. Is there anything you want to add in terms of these gaps and barriers that you've also experienced?
Absolutely. So especially in New York City, we see a lot of people that are uninsured, undocumented, and they don't have the resources available to them to get certain services. Now, I work at a crisis respite center and a supportive stabilization center, and yes, we do accept people as walk-ins, right? We do accept people that do not have the resources such as insurances, but a lot of businesses operate from a business model, which is, if we're not getting the income, how are we going to fund the programs, right? So that is definitely a big gap that we face, and actively, I'm a part of the DOH, MH, and OMH programs, and fortunately for us, we can accept people without insurances, but a lot of different programs are not doing that. So we become limited in space because even at the crisis respite in Brooklyn, we have a 13-bed capacity, right? But 13 beds for up to 28 days, what about everyone else that's also experiencing mental health and substance use crisis? Where do they go, right? So they have no choice but to be hospitalized, right? And then they're back out, just like the panelists are saying, and then the cycle is repeated over and over without really getting to the underroot and the underlying cause of the issues that people are facing every day.
Thank you. And Sasha, so you're talking about the cycle is repeated. Let's go back to you, Justina. You shared with us what the supervised release program does. Can you tell us about what are the benefits of bringing services directly to the client, especially in this model where you're prioritizing immediate service connection and in community care? And what is in community care?
Thank you. So the benefit to bringing these services directly is that our participants can really get the help that they need. And a lot of times they are overwhelmed with a lot of the appointments that they have and everything else going on in their life. So bringing these services directly to them just helps to make that transition smoother. And we have done a really great job with making connections in the community. We invite a lot of our partners into our office so that they can meet directly with our participants, because as I stated, they have a lot of appointments. It could be very overwhelming, and we don't want to set them up to fail. So bringing those services directly really help to make that connection, and we also make that connection with them, because if we are going to be sending someone somewhere, we want to be able to know what kind of program this is, what kind of help they're going to get, because we are sending them for those services.
Share with us a little bit about, you beautifully shared your story of 34 plus years clean, which is, we need a hand of applause for that. Yeah, beautiful. And we just heard from Justina in terms of what they're doing at the supervised release program. Can you tell us a little bit more about the model of the benefits of bringing services directly to the client? And again, tapping into what is this in community care?
Oh, wonderful. Yes, indeed. Bronx Hope, you don't need no medical coverage. Bronx Hope has free services. We're there. Harm reduction base will meet them right where they're at. We'll set them up with services in the community and follow up with them. Not just set them up, we'll escort them there. I can't emphasize how important that is, to be there with them with the services that we have there. Bronx Hope is a wonderful program. It's a diversion program, right? And we're just here to help them through the tough times. And like I said earlier, if need to, I will share some of my experience, some of my strength, and some of my hope with them. And the training on harm reduction is very, very important, which helps them not to go back. It helps them. We don't tell people to stop using. You shouldn't use anymore. No. Harm reduction is training people, if they're going to use safely. Here's some fentanyl testers. You know the drugs that are out there and they have now. Here's some xylazine tester strips. Here's some Narcan. Let's train them on the harm reduction. Right? I saw some people coming over here. I wish I had some Narcan on me. I would have trained at least 3 of them so they can help the whole pile of people that was there. So let's train them in a harm reduction manner. Thank you.
This harm reduction, it brings me back to what we've been saying about folks should be calling the shots, right? And so Lamarr, you shared you gotta escort them. So Sasha, I'd love your input here. So what does effective crisis response and follow-up, that follow-up that you had mentioned before, look like? Are there any helpful collaborations or partnerships that aid in that support in this stabilization?
Absolutely. I think some of the concepts are being quick, being thorough, and being effective, right? And when we say quick, it takes us back to the stabilization centers, which we're going to see a lot more of those popping up all over New York City and Staten Island, right? Where people can come in for a short-term stay of up to 24 hours, right? And even though we don't want to advertise it like this, but you want to think about it as a mental health kind of urgent care setting. We don't want to advertise it like that, like I mentioned, but knowing that you have a quick service, right? You can walk in, you're going through something, instead of going to the hospital, waiting 72 hours just to see if you make it into, the emergency room and the psych ward or anything like that. So this is a diversion away from that. So you can come in and you can meet with a social worker. You can meet with a peer specialist, someone like Lamarr. You can talk to a licensed clinician, and we give you a full, thorough assessment really quick, within 24 hours, right? So if you decide, hey, listen, I got what I needed within 3 hours, that's okay. You can go ahead. But when you leave, we're making sure that you're padded with referrals, padded with resources in the community. And we're also doing the follow-up that we spoke about, right? So what does that look like? Calling you, reaching out to you 24 hours after you discharge, up to 7 days. Hey, did you make it to your appointment? What were some of the barriers that may have prevented you from reaching those appointments that we set up in place for you? So I think being thorough, being quick and effective is really beneficial to that. Yeah, and some of the partnerships that, it's important is working with places like Bronx Hope, working with shelters, working with detox programs, right? Rehab centers, because that's where the clients are circulating with the criminal justice system. So those clients are being circulated through these systems, and it's a revolving door. So when does it really stop? Right? So this is where the impactful work that we're doing plays a vital role in people's progression and helping them to change their lives.
Thank you, Sasha. And not just people's individuals' progression, but their families, their communities, our borough, our here in New York City. So thanks for sharing that. I want to switch now to Alex. You working here in Staten Island for 8 years, we've just talked through what folks need, right? The calling, the follow-up, the escort, things that allow us to be in community support. So what does successful cross-systems collaboration look like between all of these different partners that are making it happen, between the behavioral health providers, between courts, between prosecutors and community organizers? And in that, also give us, what are some challenges?
Sure. So with behavioral health providers, there is a lot of calls, follow-up, rescheduling, scheduling appointments. With our programs with Community Health Action of Staten Island, we also do have peer staff as well who go out in the community and will sometimes go to the providers' offices if we're sometimes struggling with getting them on the phone, because that can happen when, scheduling appointments, things are fine, but with programs where clients are court involved, we have to confirm attendance. So sometimes getting in contact with providers can be a challenge. So we often build the relationships with the providers' offices where the staff, particularly the peer staff, will travel to the offices, build those relationships. So then when we call, they know who they're talking to. So that's been really helpful there to navigate that challenge. And then in terms of the collaboration with the court partners, the judge's staff, the DA's office, attorneys, communication is the biggest key. We have so many scheduled meetings and emails, phone calls, just to make sure that we have warm handoffs, we have that transition of information, so if something changes for the client, all of the partners are made aware of pretty much immediately. The judge has been doing quarterly meetings with all of the stakeholders for the treatment parts. We'll talk about challenges that are happening on Staten Island in the city. From the judge's perspective, he goes to conferences. And so we talk about ways that we can better work together and move things forward. Anytime there's been issues or concerns or, things where we need to shift or a legal partner needs to shift, we just call each other, we address the concerns, we figure out a solution. And working, I've been on Staten Island working for 8 years, but with Community Health Action of Staten Island and working with court, that's been the last 4 years. And I would say what I've seen with the developments of our partnerships, our working relationships, it's just been strengthened, gotten stronger, and we all have the same vision of helping the participants that we're working with to achieve their goals, achieve better lives. And I think that that's something that we're all aligned on, and the partnerships have been great. We work really well together.
Thanks, Alex. I think that was really helpful. And Monica, I'd love for you to chime in, because this is this perspective of Staten Island, right? Like, this is where we are. This is where the work is. And your work in the supervised release program. So tell us, what does that successful cross-systems collaboration look like in Staten Island?
Yeah, it looks like a lot of different things. So thankfully, our program has grown so much internally. I can speak about what that looks like as well. Our team has now been structured where we have a case management team, we have a community engagement team, we have a clinical team, and internally cross-collaboration looks like warm handoffs and going to the expert in whatever the issue or their concern is, so the participant can best speak to someone experienced in whatever needs they have. Outside of that, cross-collaboration usually is between us and court, the attorneys, and trying to advocate for what the needs are for the client in the moment. Sometimes that's just sharing information in court. Like, the client is probably going through something in this moment that impacts how they're meeting us in our program, whether they can be in compliance or not, whether they're having an issue with housing, because like Jason had mentioned before, a lot of our participants have housing, but then there's an order of protection, they can no longer stay there. So now we're working really hard and diligently trying to find them safe housing, and we all know the complexities of the housing systems in New York City. It's not always a very quick and easy resolve for them. So yeah.
Yeah, no, thank you. So Jason, going back to this like law enforcement perspective, right? We heard from Monica, we heard from Alex of this warm handoff. So can you tell us, like, how does your office balance accountability, public safety, and care when working with folks who are high need or even court mandated?
Sure. So, when I first took this over, when I first started the ATI program here on Staten Island, I had taken over our mental health court. And I remember having a conversation with our chief assistant, Paul Capofari, who'd been here a long time, and he said, when you make these decisions, you go to sleep every night and you hope the atomic bomb doesn't go off. You hope that when you go there and you vouch for this individual and you say, no, he doesn't need jail, he needs treatment, he needs help, he needs to go to an outpatient program, whatever it might be, that individual doesn't go and push somebody in front of a train or commit some sort of crime, because ultimately that falls on the district attorney's office. And I think one of the things that I'm most proud of in what we've built in creating the ATI program over the last 8 years, the ATI Bureau over the last 8 years, is the level of collaboration. So when D.A. McMahon first started, and he created the HOPE model, and he created all of these different, the overdose response, he got everybody in the room. And that includes all of our treatment partners. That includes all of the different city agencies, the defense bar, the court. Everybody got together and we collaborated together to create this. And one of the biggest things that I've really focused on in starting the ATI Bureau and really helping to launch our different courts on Staten Island is that collaborative piece, right? It is very much an adversarial system. It's us and defense and the court. But in that ATI part, it's not adversarial. We've built relationships. We've built a part where everyone, my team, Alex's team, I know that Abby from Task is here. She's a huge partner in this. The court, we're all working together to help that individual. So we've now gotten to a point where when David or Austin or myself want to talk to a defendant, 5 years ago, defense would say, you're not talking to my client. Now, they're going, hey, Jason, can you talk to my client real quick? They're calling David and saying, hey, we resolved the case, but he needs a detox. Could you help? They have their own social workers. They're calling the DA's office. And I think that just goes towards how important it is to collaborate, to build that sense of community, right? We meet with our Supreme Court and criminal court judge every week with all of the partners, with Alex and her team, with Abby and her team, with the defense to talk about each person individualized. How are they doing? What are their needs? When they're in court next week, what are we doing for them? And I think that working together is such a huge part of it, and it's a reason why we've seen our overdose rates and our recidivism rates drop so drastically here on Staten Island compared to everyone else, because in the end, it's a team effort. And I think that's citywide, right? But we are lacking a lot of the resources that they have in the Bronx and Queens and Brooklyn and Manhattan. There are all these great programs that operate citywide, but they have no presence here. So we're rolling up our sleeves and we're doing it together, which I think shows the resilience of Staten Island.
That's amazing. Recidivism rates dropping, right? Collaboration just increasing. Justina, tell us a little bit about how, with the collaborations increasing, with more support happening here on Staten Island, like how are programs and citywide, right? But we're here on Staten Island, so we're gonna rock it. We're gonna rock it. But how are programs adapting to like these increasingly complex clinical needs? I think you have a perspective here of like what staff trainings could potentially look like.
Yes, thank you. So we do offer a lot of staff trainings for our staff on topics such as trauma-informed care and different types of interventions to best support our clients. Because like you stated, the client needs are constantly changing. But what we also do is we do have group supervision for all of our staff where they can come in, talk about their cases. And we also recently incorporated case conference, which is led by me, and Monica is also involved in that. And the case manager can bring their cases to case conference. The community engagement team also joins those case conferences, so we really talk about the complex clinical needs and come up together with a way to best support the client, because even though that client may not be on our caseload, but it is, if the client is in our program, then the client is all of our clients. So it's important for us to all come together and like help, because the needs are so complex and we can't do this work alone.
Sure. We've heard so much today from, I think, different perspectives, and I think it's been really helpful for me as somebody not in this sector, understanding what the increased collaborations have looked like, what are the different misconceptions, how are we meeting people where we're at, and so we're gonna bring this all home now. We're gonna bring it home, and we're gonna ask one final question. And Justina, I'd love for you to start us off. So now that we know what's going on, and our audience knows all the great things that are happening now. So now we're gotta think ahead, right? There's so much happening. We got the rise of AI, we got different things happening in our government. What is one shift, whether in policy, practice, or collaboration, that you hope to see that would meaningfully improve support for individuals with complex behavioral needs?
So I think there's a lot of work that still needs to be done. We definitely need to provide more education for the community, for people involved in that individual's life. We also need to increase housing resources and work on insurances. I know sometimes when we send people to an inpatient substance abuse program based on their HMO, that will depend on how long they will stay. So sometimes we'll send them to a 20-day inpatient program, but because of their insurance, the insurance will only cover 14 days. So I think, there's so much work to be done in every area, but definitely training, education, and like all of those things that I mentioned. There's just so much that still needs to be done.
Thank you. Monica, I'd love to hear from you.
Thank you. I think Justina hit on some really big points. In Staten Island, I know for me it's always been a bit difficult when we're meeting participants who are in recovery and who are in need of detox. Finding detox in Staten Island is impossible. It's not going to happen. So that's probably an area in which Staten Island can benefit from a bit more. Definitely more funding when it comes to detox, inpatient, and probably even outpatient counseling.
To expand upon what Justina was talking about with education, I think that, public education and education for family and friends is really important about mental health and substance use and even harm reduction. I'm sure there's people in the audience who may not have even have heard of harm reduction methods, and that it is, it's backed by evidence, right? There's so much that people don't know, and having the support with the education for family and friends, I think, should be really highlighted, because someone who's dealing with mental illness and substance use it's not just them alone, right? What they're dealing with also does affect the people around them, and the people around them could also benefit from support for themselves. So there being more awareness, support and education for friends and family to be able to navigate their own, things that may come about when they have someone in their lives that they care about and love who's dealing with these issues, but to help themselves, like, clinical and therapy for themselves, but also how do they support their loved one? What does that look like in real life? We all have what we think we would do or think we would say to a person in our lives that we care about, but there's maybe, with that education aspect, different ways that those things can be navigated to better help you and your loved one. So that education and then the support available for the community is also really important. And I think that going forward, that should be something that hopefully, the city, we can invest in that more.
Okay, we're hearing education, we're hearing care and support. We're gonna hear from everyone. So back at you, Jason, Lamarr, and Sasha, thinking ahead. What is one shift, whether it's policy or practice or collaboration, you hope to see that would meaningfully improve support for folks who have complex behavioral health needs?
So I think the education piece is really important. And not just for the community. I think, again, coming from the legal perspective, coming from that law enforcement perspective, there has to be that education for our first responders. The amount of times that you see police or firemen or even EMTs who are going into a home of somebody who is severely mentally ill, and rather than, mom called the police just to get them to the hospital. And rather than de-escalating the situation, they escalate the situation. Now this person, God forbid they shove or they hit an EMS worker or a cop. Now they're charged with assault too. And instead of getting the hospitalization, the help that they initially needed, they're in jail. And they're looking at 5 years state prison. And luckily we do have these ATI programs for these individuals. But I think that training is a very important piece. And for our courts and our court staff. A lot of our courts and our court staff, we are very lucky to have two incredible judges, Judge Bijou Koshi, the supervising judge of the criminal court, who also oversees our ATI parts, and Judge Marina Coramundi, who is our Supreme Court judge that oversees our Supreme ATI parts. They're good, they have a really good staff. Other judges and other court staff are not. And I think that makes or breaks a part. It also makes or breaks an individual's success. And when the stakes are as high as a state prison sentence for an individual, I think it's unfair to them to put them in a situation where they're set up to fail due to the lack of education from the courts or law enforcement. Again, I always bang the drum of we need supportive housing, we need more things in the community. Housing is such a huge part of our needs here in New York City, obviously. For a lot of these individuals to have to go to a shelter, we're setting them up to fail because they're not getting the services they need there. They're not getting any services there for the most part. So I think that's a really important part. And just look, being from Staten Island, she said it, we've all said it throughout, we don't have the same resources here. We don't have a presence from health and hospitals. We don't have a city hospital here. We just have 3 private. We don't have the same ability, and it's something that you see throughout the city. I think it's highlighted here, is you have this person, they just got out of Rikers Island, they're schizophrenic. They're maybe 70% medication compliant, but they really didn't get the medication they needed that they're in there. So they get released from court. And then they're told, you need to go to this program. It's in Queens. Here's one Metro card. But then they get there and they're told, no, you need to go to Brooklyn for this thing because you didn't get this piece of paperwork. And then they're sent over back to Staten Island. Even the run around here, we have the Family Justice Center model, which I think is fantastic for intimate partner violence. But with people who are dealing with substance abuse and mental health, go to court, get this paperwork, then go to the 120 precinct because you didn't get your voucher, then go over to Edgewater, but you didn't go to probation first, and that's back the other way. And we're sending these people on a runaround who often are decompensated, disorganized, and we're not doing them, we're doing them a disservice.
Thank you so much, Jason. Bring us home, Lamarr and Sasha. We just a couple of minutes left, and so bring us home, wrap us up here.
All right, sure thing. Bronx Hope, we have a office on wheels. We can outreach the community. We can do personal engagement outreach. So it's a wonderful tool that we can escort clients to get their medication, that we can take them to their appointments. We can help them fill out these applications. We have groups. Our Bronx Band is a safe space that we could meet. We go to their house, we go to their homes, 2 of us, not one at a time, and we can go to these communities, personal engagement. Bronx Hope is wonderful. I'm glad we have the resources. I don't mind sharing it with Staten Island, Brooklyn, Queens, and Manhattan. We can share it and we can do this job together. One team, one dream. Teamwork makes the dream work. Thank you.
That's that Bronx love. Sasha, wrap us up for us.
Yes, thank you. So, I mean, you guys pretty much spoke about everything, and I think the most important part is collaborating with the FDNY and the police officers, right? Because one of the things that we've been trying to do at the Stabilization Center is getting them to reroute to us, right? To the crisis centers, to the respite services. However, in their protocol, they have to bring people to the hospital. Right? So that is something that we need to do on a larger scale, working with the Office of Mental Health, the DOHMH, and all of the collaboratives that we've been working with, right? How do we stay connected with the police officers, with the FDNY, so that they know that these resources are an alternative service that we can provide to the community, right? And I heard the regular stuff like Metro cards, right? Being able to provide people transportation from service to service. That's really important. Some people are not even travel trained, so they don't know how to get to, Bronx, to Queens, to Brooklyn. So that's definitely